Welcome to Gamble with Brandl. Today we have a patient that was recently started on Celecoxib for hip osteoarthritis. Which of the following was most likely the reason for starting her on Celecoxib and not on another traditional NSAID? And here we are given a couple of options: Ray's syndrome, asthma, myocardial infarction, or GI bleeding. So what was her past medical history that led the physician prescribe Celecoxib? So what is Celecoxib? Let's start with that. So it's a selective COX inhibitor. So that's what the name says. Celecoxib. Selective COX inhibitor. Selective for COX-2. And you probably know there's COX-1 and COX-2. The traditional NSAIDs, things like ibuprofen, generally target both COX enzymes. Aspirin in low dose is more specific for COX-1, but in higher doses also blocks all the COX. So Celecoxib is actually the only one on the market that just blocks pretty selectively COX-2. Now, what could be a reason why she got prescribed that? Now let's think about the options. Ray's syndrome. Well, Ray's syndrome is something that we see when we treat kids with aspirin. And that's mainly happening when you give kids with a viral infection aspirin, and that results in severe liver and brain damage. So that has definitively nothing to do. That's more an aspirin adverse effect and very specific for children. Now, what about asthma? Well, asthma, all respiratory distress reactions can occur with any of the NSAIDs, and that even has an own name. We have something that's called NERD, which stands for NSAID exacerbated respiratory syndrome disease. And why is that? Well, when we make prostaglandins, they come all from arachidonic acid, and we use the enzyme COX, COX-1 and COX-2. And also when we make leukotrienes, we use the enzyme LOX. So we have from the same precursor arachidonic acid, we get prostaglandins and leukotrienes. Now it turns out that the leukotrienes stimulate bronchoconstriction, which is obviously not something you want to have in asthmatic patients. And the idea is, if you block COX enzymes with any NSAID, well, then you're going to have less prostaglandins, but you still have the precursor around, so you're going to make more leukotrienes, and therefore you stimulate exacerbate respiratory disease. Aspirin does it also, and it has another name, but it means basically the same thing. That's called ERD for aspirin, exacerbated respiratory disease. So that's something we see with all the NSAIDs, so that's also not likely a reason why she got started on Celecoxib. Now, what about MI, myocardial infarction? Well, myocardial infarction is actually something that you're more at risk when you take Celecoxib compared to a traditional NSAID. And that's also the reason why many of this COXib, the selective COX inhibitors, were taken off the market, and now we have only Celecoxib left. And why is that? Because there's such a yin and yang between two of these prostanoids, and one is thromboxane, which promotes platelet aggregation, and there's prostacyclin that inhibits platelet aggregation. Now it turns out that thromboxane is mainly made by platelets in a COX-1 dependent fashion, and prostacyclin is mainly made by endothelial cells in a COX-2 dependent fashion. So let's start thinking first, okay, what's going to happen when I use Celecoxib? Well, then I'm blocking COX-2 with Celecoxib. So this goes away. So I'm going to promote platelet aggregation, which means I'm going to be at increased risk for MI, stroke, thromboembolism. So in fact, when we use Celecoxib, she would be at increased risk for MI compared to maybe other traditional NSAIDs. So that's definitely also another reason. And you probably also know that aspirin in low concentrations is used for the prevention of cardiovascular disease like MI and stroke. And why is that? Well, in low concentration, aspirin blocks COX-1. So if you block this pathway, well, then you have less platelet aggregation, which makes you less of a risk of developing MI, stroke, and thromboembolism, which is the reason we use aspirin for the secondary prevention of cardiovascular disease. Okay, the last thing, and this needs to be now our correct answer, is GI bleeding. So maybe she had a GI bleeding. And in fact, it turns out that particularly prostaglandin E2 is very cytoprotective. So what it does is if you have it, it makes you more mucus, increases mucus production and bicarb, and less acid. And this is mainly made in a COX-1 dependent fashion from arachidonic acid in the GI tract. So let's draw here a little stomach. That's what's happened in the stomach. So you're gonna have on board this prostaglandin E2. And if you're using a non-selective COX inhibitor, you're obviously gonna block this, and then you have less mucus, more acid, and that's not good in a patient that had any underlying GI disease like a previous GI bleed or peptic ulcer disease. So in that cases, you want to avoid this traditional NSAID and may go for something like Celecoxib, a selective COX-2 inhibitor.